Now I invite Dr. KALAIMATHI Madam from Giridhar Eye Institute to give a talk on optic atrophy.
Thank you, sir. Good evening, everybody. My topic is optic atrophy. If you see a optic disc like this, unilateral or bilateral optic atrophy like this, how are you going to proceed? First, with the history itself, the etiology of optic atrophy can be found out in 92% of the cases. And if the optic atrophy is unilateral, and if the patient is young patient, the diagnosis is the cause for the optic atrophy is optic neuritis, that is inflammatory. And if it is a unilateral optic atrophy and the patient is relatively old, the cause for the optic atrophy is inflammatory, that is it could be anterior ischemic optic neuropathy. And if it is bilateral, the cause for the optic atrophy could be nutritional, Leber's, toxic, hereditary, or could be because of idiopathic intracranial hypertension. So, if the cause for the visual loss is sudden, then we have to think in terms of vascular etiology, and if it is subacute, then we have to think in terms of inflammation. If the visual loss is gradual and progressive, we have to think in terms of compressive or nutritional etiology, or if it is static, we have to think in terms of ischemia or trauma. So, past medical history is very important in bringing, important in diagnosing the etiology of the optic atrophy. History of infections like TB and syphilis is important. History of any trauma, surgery, and history of any intake of medicines like ethambutol should be asked for. And any substance abuse like alcohol, tobacco should be noted. And any systemic diseases like hypertension, diabetes, myocardial infarction should be noted. So, a comprehensive ophthalmic evaluation should be done starting from best corrected visual acuity, color vision, pupillary examination, slit lamp examination, and optic disc examination is very important. It gives clues regarding the cause for the optic atrophy. For example, if there is cupping, then we can think in terms of glaucomatous optic atrophy, and if we have to examine the optic disc of the other eye also. For example, if the other eye optic disc is small and a cupless disc, then we have to think in terms of AION in the affected eye. If there are optociliary collateral vessels, then we have to think in terms of optic nerve sheath and meningioma. And if it is a bow tie atrophy, then we have to think in terms of chiasmal lesions. So, in any case of disc pallor, you have to examine under magnification and under green filter. Then go ahead with the ancillary testing like automated perimetry. And if it shows any central field defects, then we have to think in terms of nutritional or toxic optic neuropathies. And if it is hemianopic field defect, then we have to think in terms of chiasmal or retrochiasmal space occupying lesions. And if it is altitudinal, we have to think in terms of ischemic. Then go ahead with MRI brain and orbit with contrast with fat suppression. And in case of optic atrophy, 20% of the optic atrophy is because of compressive lesions, which could be detected by MRI. And if MRI is negative, then go ahead with blood test like syphilis serology and quantiferon TB, chest X-ray, etc. And finally, you can go for genetic testing for LHON and dominant optic atrophy. Coming to the cases, 57-year-old male coming with history of blurring of vision, 3 years duration. vision right eye 618 and left eye no PL, RAPD left eye, color vision right eye defective. This is the both eye optic atrophy. We had sent for a MRI which came out to be both a bilateral optic nerve and optic chiasmal atrophy. Then when he came with the MRI report, only then he revealed the history of heavy smoking and drinking. So this is a case of toxic optic neuropathy. From the very history, we can come to a diagnosis of this optic atrophy. Straightforward case. The second case, 42-year-old male, history of RTA 4 months back, defective vision right eye, CT orbit fracture, floor of right optic canal, RAPD right eye, IVMP given, vision right eye PLPR inaccurate and left eye normal. This is the fundus picture. Again, this is right eye optic atrophy. This is primary optic atrophy because the disc, there was no previous disc edema, and the pathology is behind the disc. So this is primary optic atrophy. From the history itself we can make out it's a clear-cut case. This is a traumatic optic atrophy. Sudden diminution of vision, 3 days duration in the left eye, and diminution of vision right eye for 1 year duration. Smoker, vision both eyes counting finger 1 meter. This is the fundus picture. The right eye optic atrophy secondary to CRVO. This is secondary optic atrophy secondary to CRVO, and you can see the disc margins are not clear, it's blurred, and because of the previous disc edema. So this is secondary optic atrophy. 57-year-old nurse came with diminution of vision, gradual onset, progressive in nature. Vision right eye 636 N18, left eye 660 N36. Both eye disc pallor. This is the fundus picture. Slow, progressive in nature. The history is diminution of vision, progressive in nature. She took ATT in 1995, developed diminution of vision, and after which ethambutol was stopped. So this is again toxic optic neuropathy. From the history we can make out, and this is again primary optic neuropathy because the disc is the pathology is behind the disc. 72-year-old male, vision right eye 6/6 N6, left eye 6/12, left eye RAPD, and both eye had slit lamp examination revealed both eye peripheral iridectomy, and he was on anti-glaucoma medications for more than a year. And this is the fundus picture. Right eye was normal, left eye was had optic atrophy. So from the history we can make out that he had glaucoma. So this goes, the diagnosis is glaucomatous optic atrophy, and this is cavernous optic atrophy. And the ancillary testing field is confirms the diagnosis. This is cavernous optic atrophy. 62-year-old male, blurry vision both eyes, difficulty seeing at night, no family ocular history. Vision right eye 6/18, left eye 6/9. This is the fundus picture. This is a very clear-cut case. This is a consecutive optic atrophy secondary to retinitis pigmentosa. 33-year-old female, headache 2 years duration, vision 6/6 N6 in both eyes, pupil normal, cycloplegic refraction done, slit lamp normal, fundus, both eye mild temporal pallor. She was called for PMT, and during the PMT color vision was checked because of the temporal pallor. It was normal, and she was given glasses, plus 0.5 glasses was given. And this was the fundus picture, bilateral mild temporal pallor. And she came back after 3 months with no improvement in headache, Again, vision, color vision and pupil was checked. It was found to be normal. So we did a field testing in which the right eye had generalized reduction in the reduction in sensitivity. So we were not happy with the field testing. We ordered a MRI. It came out as microadenoma of the anterior pituitary. So we revisited the history. She had amenorrhea and later on she developed galactorrhea as well. So she was referred to a neurosurgeon and she was treated medically. So any even mild temporal pallor, you have to go for optic nerve function test, and if necessary do a field test is mandatory, and if necessary can go for MRI. 69-year-old female, defective vision left eye 1 month, defective vision right eye many years. Right eye 6.9, left eye 6.12 N8, color vision left eye defective. Fundus right eye pale disc, left eye disc edema. This is the right eye and pale disc, left eye disc edema. This is the right eye disc edema in 2013. Okay, so now the status is right eye pale disc because of the AION in 2013. And in 2013 the left eye was disc at risk, which was the disc was small with cupless disc. That is the point to be noted. And now that disc at risk has become developed AION now. And the second point here to be noted is the right eye pale disc has a vision of 6/9. So the vision and the pallor does not correlate with each other. This is the altitudinal field defect. Defective vision 2 years, progressive in nature, right eye normal, left eye no PL and RAPD. And left eye optic atrophy, operated for sphenoidal wing meningioma. This is a primary optic atrophy because the pathology is behind the optic disc. Coming to the non-pathological causes of pale disc, if you examine the optic disc with bright illumination like indirect, the disc might look pale, and in case of any progressive myopia, the disc may appear very pale, and pseudophakic disc also appears very pale. So to summarize, systemic approach through history and examination, we can come to the etiology of optic atrophy. Automated perimetry is mandatory. Laboratory tests are useful only for specific diagnosis. Unexplained isolated optic atrophy imaging is necessary. Patients showing signs of progressive optic atrophy, frequent follow-up and re-imaging is necessary. And if non-progressive, follow-up can be gradually discontinued. Thank you.